Good morning. My name is Michelle Lavelle Henry, a member of the Westminster Social Justice Ministry team. We build the social justice forums around a common theme, and this program year, the theme is moving from understanding to transformation, affecting change through guided by God. Through these forums, we want to explore capabilities we need to build and examine to be effective transformation partners in our community. This morning, we are pleased to announce and welcome Dr. Courtney Jordan Baechler, Medical Director of Health Equity and Health Promotion at the Minneapolis Heart Foundation. She previously served as Assistant Commissioner for the Minnesota Department of Health and currently serves on the Minnesota Department of Health Mortality Review Board for the Department of Health and and she is program director for the Minnesota Department of Health Prevention of Cardiovascular and Stroke Committee. Courtney will be addressing racial and gender justice in cardiovascular health. This is an opportunity to understand more than just the numbers, but to help us understand how we have gotten here and explore possible solutions and discuss how we change the future trajectory. But before we get started, we have a few items to go over. Westminster social justice forums provide with the opportunity to learn and interact with ideas. The Social Justice Committee hopes the forums inspire us to further God's justice in the world. Towards that end, the team offers these guidelines for question and answer time. And I would like you to just review these briefly on your own. We'll just give you a second or two for respectful comments, questions, and answers. Welcome, Courtney.
Well, good morning, everybody. It's so great to be here, and I'm so thrilled that your church has this type of series. I really think that there's a huge opportunity for social justice, specifically as it relates to some of our healthcare disparities within churches and various neighborhood organizations. So I'm going to talk a little bit first about why this is so important to me and what has motivated me for a long time. So this is a picture of my dad and my son, and they both were born here in Minneapolis. My dad, Michael Jordan, was born about 5 blocks from where George Floyd was murdered, and my son was born at Abbott Hospital over on 28th in Chicago, and they right now, even though I'm a little part that connects the two of them and happen to be a cardiologist, have very different trajectories in terms of their cardiovascular health, simply because of the color of their skin and where they live. And so I want to talk a little bit more about what this means, how we can change that, and again, get beyond just the facts and figures into where this comes from. So I'll never forget being a second-year medical student. And sorry, I should just say, please interrupt me with questions. I actually prefer that as you have them and as we go. Otherwise, we'll definitely leave some room for a conversation at the end too. But when I was a second year here at the University of Minnesota, I'm proud to have done all of my training here in Minnesota. But I'll never forget at the very end of a lecture on breast cancer, because the data I'm presenting here is specific to cardiovascular disease, yet is true really of all of our health overall. But I was in a lecture on cancer, and at the very end, the last question the professor said, the last statement was, and Black women are less likely to get breast cancer, but they're more likely to die from it. And I, went up afterwards, and I was a math major. I said, this makes no sense to me. Like, how does this work? And he said, oh, they get more aggressive cancer. And I thought, oh, okay, well, that maybe makes sense. And it was my 4th year of med school where I had a chance to do a project when I was working at the Broadway clinic on the north side and specifically look at some of these disparities. And so I chose breast cancer at that time. And sure enough, there's absolutely no data to substantiate any difference in the type of cancer people get based on color, but it's all about all of these things that we're going to talk about, systemic biases, when people present insurance coverage, you name it, and racism. And so as I looked further into becoming a cardiologist, I saw this come up over and over and over. So the first thing that I want you guys to understand and just to appreciate, this is back from 1996. This is not new, but we are 99% the same genetically, whether we're talking about race, gender, anything. We are much more alike than we are different in terms of our actual genes. And so there actually isn't any genetic basis for the disparities we see in healthcare outcomes, whether we're talking about women or whether we're talking about race and ethnicity. And I'm sure many of you have seen these figures, you've heard them in the media. There's essentially not a single disease or statistic that you can look at where people of color and our Native population don't do worse. And then if you layer on gender, women do the worst in these categories. And there's just some of them that you can see here. People of color have the highest rates of heart disease in the country, 2 to 3 times more likely to die of heart disease. While we see overall mortality rates decreasing for white people, we don't see the same decrease in mortality for our Black population. If you are on Medicare, you're 42% less likely to get a defibrillator, that's an ICD, after a heart attack if you're a person of color. And then again, if you present to the emergency room and you have chest pain, if you're a woman and you're a Black woman, you're less likely to get an angiogram for that chest pain than our white counterparts. And so again, I'm going to kind of move into hopefully the more fun stuff, because we all know that this data is horrible. But again, here's looking at moving things back a little bit, blood pressure control and prevalence rates based on race and gender. And again, we see the highest rates of high blood pressure in Black women. And just remember that very first slide, we just said it doesn't have anything to do with genetics. And then we look at who gets hospitalized in terms of folks with diabetes, which we know is a risk factor for ultimately developing heart disease, who has well-controlled blood sugar or glycemia, well-controlled cholesterol, well-controlled blood pressure again. So you're less likely to have any of these things at optimal control. Again, as we talked about, this is not a genetic piece. So I think those are some of the national data. And then what I like to do, oftentimes people feel like it's different in Minnesota, nice. And I know I have been super proud that we've had the best heart cardiovascular outcomes since 1999. And as a practicing cardiologist here, that makes me super excited. However, when we look under the hood a little bit more, it's not true for everyone. It's really, unfortunately, our white population that has done quite well, and we actually have some of the largest disparities in the country, worse than some of the Delta region in the southeastern area of the U.S. when we look at some of these things closer. So you can see here, if you're African American or American Indian in Minnesota, how you fare compared to our white population. And basically, it's not into the 7th and 8th decade where these start to normalize. And again, we're just breaking that down by that age group, and you can see, again, unfortunately, particularly when folks are younger. I will still never forget growing up, and when my dad turned 58, which at the time was the average life expectancy for a Black man in Minneapolis, and that it was a big deal in our family to have him overcome what was the expected lifespan. So this is very real and near to my heart. And I guess I should have said from the very beginning, my brother and sister and I were all adopted. I'm Persian. We all have a different racial and ethnic background, and have had this incredible opportunity to have been adopted by a Black man and a white woman, both who lived here. as children. And so this is very real and near to me specifically, knowing what it was like to grow up eating the same foods, moving the same ways, living in the same house, and again, yet have these very different things that don't have a biological basis. So you can see here when we start to look at how did we get here, we talk about, again, some of the blood pressure pieces, that which if we could only change one thing, blood pressure would be the thing that we would change to have the biggest outcome long term. And you can see whether or not by race there tends to be optimal blood pressure control. And unfortunately, here in Minnesota, that's less likely to be controlled if you're Black or American Indian. We also have these optimal vascular scores, which basically, again, look at cholesterol, blood pressure, blood sugar, those types of things. And you can see, again, this is data that we've been tracking at the state. And certainly Gretchen has been a big part of putting all of this together for us to be looking at what we should to have the data to make some of these changes. And you can see, again, you're less likely based on race and ethnicity to have these at goal. So again, since we're saying that it's not these biological pieces that account for this, what are accounting for these? And a lot of this are these social determinants that you hear so much about. But look here specifically at how much your zip code matters, right? And so where you grow up and where you live has a huge impact in ultimately how long you live. So here we are over in the Medina area with the longest life expectancy in Minnesota of about 92. Here we are, where close to where my parents grew up, where the average life expectancy is 67 in the Elliott Park area, and then the lowest life expectancy over in the Rondo area at 65. So again, this really matters, and we know that 80% of our health is determined outside of healthcare. So again, it is determined in places like churches and schools and neighborhoods and nonprofits and all of these areas, yet we often have this assumption that it happens. I had that assumption that it happens in the clinic, where you spend maybe 15 minutes, maybe 30 minutes a year, depending on your health. And unfortunately, the majority of our dollars that we spend as a country go into that 20%. Within those social determinants, education, and actually education of the mother, is the single strongest predictor of lifelong health. So when we look at that data for who is graduating overall from a race and ethnic perspective, you can see here what it looks like for Minnesota, where 87% of our white population is graduating and only 65% of our Black population and American Indian population at 53%. So the need to marry these two areas together is really critical. But once again, the way we fund things, I can't tell you how many times right now I have a program called Girls Taking Action that I do with 16 to 18-year-old young women who have various socioeconomic challenges, and it's specifically a micro-credential in cardiovascular health. To get funding for that, for people to appreciate that these are connected, and ultimately to control somebody's blood pressure means having this type of intervention in the schools then, is a total mind spin for people to say, you're out of your lane, this is education, this isn't health, but actually they're critically connected. And you can just see some of the other areas that go along with that. So whether or not you're you get diagnosed with diabetes, you can see how that correlates with having a diploma, high school diploma or not, whether or not you get prenatal care, adequate prenatal care, which again is a huge area that I'm involved in at the state level. When we look at the disparities we have from a maternal mortality perspective, they mirror all of this. And then whether or not you smoke, same thing. We know income is also directly related, and you can see here the disparities that we have within Minnesota. I think what particularly stands out for me is that if you are a U.S.-born Black person, your income is actually often lower than newer immigrants from Africa, which is really says a lot about how racism has played in over the years. Home ownership, a lot of my time at the Department of Health spent time working with communities, specifically around health equity. And the number one thing that people talked to me about when we talked about mental health and ability to be in control of their health situation was when I don't know where I'm going to live next month or have challenges with rent and all these different pieces, it's impossible for me to schedule an appointment, to have my medications, all of the things. So just look at, again, home ownership and who tends to own homes here. 77% white people own homes versus 25% of our African-American population. So, and we know, and I think you guys probably wouldn't be here if you hadn't heard some of these statistics before, in terms of redlining and all sorts of systemic racism that has been a part of our very near recent history. I know myself, having lived in the country club area in Edina, how specifically having those conversations with my dad when it was very recent that country club changed their own rules and guidelines that people of color could actually live there. So this is not long times ago, right? So when we put that all together, income, housing, and health, you can just see, again, I'm focusing as a cardiologist on cardiovascular health, but whether it's cancer, COPD, arthritis, depression, diabetes, asthma, smoking, binge drinking, and obesity, the connection there, if people are financially stressed about their housing and the likelihood of having these various diseases. We also know in the land of 10,000 lakes, and I think we call it something different now, even more than that, we have, that's part of what I love about Minnesota. I love that we're if you're in Minneapolis, you're within blocks of a park, wherever you go. But unfortunately, who's accessing these areas is completely different. And we know that people of color are more likely to note safety concerns in our park system and being uncomfortable and concerned about using some of these free spaces that we have to be healthy. So, and we know, right, our ability to move, have access to great foods, and have a low stress life directly connects to obesity rates. And we can see there where those rates of obesity are, with the highest rates being in our American Indian population and our populations of color. I'm sure you guys have had some conversations about social justice as it relates to the criminal justice system. And again, you can see on the left part of the slide, based on whether you're white, black, or American Indian, and the likelihood that you end up in prison and jail. And I think you guys have, again, probably all heard these statistics about reading levels at third grade and correlation with prison cells, of what we do from a state perspective. And there's a lot of work that needs to be happening there as well. That was another part for me that at a young age, my dad was teaching classes on driving while black and just helping people understand the realities here in Minnesota of what it's like. So this is not new to me, and there are direct correlations with health outcomes. I'm really proud of the work that we've done as a state, or that we're continuing to do as a state. I'm the first cardiologist to serve on our maternal mortality review committee, where, again, what we're looking at is during pregnancy and then the year after, what we call the fourth trimester, of who is dying. Unfortunately, the rates of disparities in this, again, based on ethnicity and race, you're much more likely to die during pregnancy if you're a woman of color or a Native woman. And the number one underlying cause for that are cardiovascular causes. Thanks to Rachel Hardiman and many others, but our own local Dr. Rachel Hardiman helped at the national level add racism and discrimination. So Michelle and I were just talking about how now when we review deaths, we actually go through the charts and look for different words that show that show how these folks are experiencing discrimination in the healthcare that they're getting. So not just whether or not they got the right treatment at the appropriate time, but how folks are labeled when we talk about non-adherence. Even when in medical school, when we're taught, and I remember questioning this at Hennepin County, you're taught outside the room to present the patient to your attending physician as a 35-year-old Black male presents with chest pain. And there's actually no biologic basis for that. The closest thing that you can maybe get to is sickle cell, which is extremely rare in our population. But you're painting a picture, right, for people from the very beginning. And usually, back in the day, we were actually taught, to label their size. 35-year-old obese Black male presents with chest pain. And we know, right, for good or bad, that our brain has been programmed our entire life to be assessing these types of patterns and things. And unfortunately, it leads to some of the bias that we have. So we have a lot of work to do in the healthcare setting as well. Part of my interest in all of this is we know, cardiovascular stuff starts during pregnancy and really is kind of the first stress test, if you will. And so again, we see, unfortunately, this is some of the research that I'm doing right now, higher rates of diabetes that develop in pregnancy, high blood pressure that develops in pregnancy, and preeclampsia that ultimately then increase your risk of heart disease later. So if we can, at a minimum, again, we'd love to do this at birth, but start to get ahead of this and make sure that people get adequately treated during pregnancy and then afterwards, and you start to remove those barriers, that's a huge piece, which is a trial that we just finished doing and a paper that we just published in sort of our Bible of cardiovascular care on our own disparities at Abbott currently. So I mentioned some of these challenges that we have in academics in Minnesota or throughout our country, but it's really, really important. Number one, there was some garbage about people of color being more salt sensitive, that there was a gene. The current guidelines on what drugs still to this day that you put people on at the beginning of high blood pressure is race-based and is wrong and still needs to be removed. So it's a board question still. If you have a Black person, they should be on a calcium channel blocker, and that's a flawed study. It's an inferior drug and has all sorts of other cardiovascular ramifications when we do that. So that's a problem, but it's still there. I had the great or unfortunate opportunity, whichever you want to say, to be a part of a BIDIL study during my time at the University of Minnesota that was a drug looking at heart failure patients that did not have a positive outcome for the overall population. And so they went back, which is not how you do research, and looked specifically at what happened with the Black population. It's a drug called BIDIL. It's a combination of hydralazine and Imdur, and got an FDA patent only for Black people. It was a super expensive drug. It's still in the guidelines, and it's been completely debunked, but it's still in the guidelines. And this is a great thing that medical students at the University of California, Berkeley put out. I would strongly encourage people to read it, but this is very recent. And then finally, we're just in the last 2 years getting rid of this GFR, or glomerular filtration rate, which is when you get an electrolyte panel with your sodium, potassium, all that. At the end, there's still healthcare systems in town that have this something that says, if you're Black, it's this, if you're white, it's this. Totally wrong. No genetic basis for that, but it's taken like 20 years for us to recognize and move that out. And finally, on my panel still, when I go to calculate your 10-year risk of whether or not what the likelihood that you're going to have a heart attack or stroke, whether or not I would suggest putting you on a statin drug or not, at the very end, there's a box to click if you're Black or white. It's still in there right now, today. And it's totally wrong. And by the way, what do you do when you have a person of color that's half white, half Black, or 75%, 25? I mean, it's just so crazy. It makes zero sense. And while I was not on the committee that put that together at the national level, I know that, like many things in medicine, that was well-intentioned, because of the disparities that we see, but it's actually wrong and it's not fixing the right problem. Yes.
I assume it increases risk, so therefore it should start treating intervention sooner.
Correct.
Or I asked if it was essentially the race-based thing is increasing risk, so that in theory, the interventions that are going to help their health outcomes
Correct.
are better. So in
Correct.
some respects, it's a product of trying to alleviate the gap, but it's in some ways also utilizing the gap to. It's a bad cycle.
Exactly. You're absolutely right. And that's what I'm trying to say is that is part of the problem, right? It's not, that is part of systemic racism, right? It's not the person being black, which is what the question is. It says, are you black or white? It is all of these other things. And I will tell you, for anybody who hasn't done this, go and have a conversation with 30 young black 15-year-old girls and go through this data and try to explain to them at 15 why their genes are increasing their heart disease, and there's nothing there. And so that's why we have to, especially as physicians and scientists, we have to tell them what the data actually is, and it has nothing to do with their genes. It has everything to do with the systems that we've put in place. And so that is why, while it's well-intentioned, it's completely flawed. And I was just telling Michelle at my time at Hennepin County in fellowship, I feel like Hennepin's one of the best hospitals out there. Most of the doctors that are there practicing are called in some way to be specifically with patients that are marginalized and have more challenges. But during my time, it was when we had bare metal stents and drug-eluting stents. Drug-eluting stents were clearly superior. When you take a drug-eluting stent, it requires that you're on Plavix for a year. You are less likely to get Plavix there because if you had a socioeconomically challenging situation, because we saw people come in over and over and over with their stents closed off. So we thought we were doing better by putting in an inferior stent versus solving what the actual problem was, which is getting Plavix to the right person in other ways. Later on, papers came out that if you're black, you're less likely to get a drug-eluting stent. I thought, well, of course, I was just taught that I'm doing right by patients, but you're actually doing wrong, and you're a part of the problem. So I just mean that takes a lot for us to look in the real mirror and say what the problems are versus making an assumption for somebody else and giving flawed information. We're creating some of the high blood pressure in people by making it assumed that you're going to have a bad cardiovascular outcome simply because of the color of your skin. So we have a lot to do. And you can just see as we're talking about that it is very multifactorial, from communications, how people want to heal, clinician bias, like we just talked about, historical trauma. I think we all know about the Tuskegee trials where we had cure for syphilis, but withheld it from black men to be able to see outcomes long term. We just talked about evidence-based medicine and references that are inappropriate and inaccurate. We know that the time of clinical presentation is critical, especially in heart disease, and we have to make it easier. Trust, insurance coverage, and access are all big pieces. So there's a lot more awareness and ownership within the American Heart Association and the American College of Cardiology. These are articles that have been published in the last year, just talking about some of the things that should happen: eliminating out-of-pocket expenses, moving where we do healthcare to actually having it be in the communities. Take a look at the amount of healthcare that's on the north side, and then take a look at what we have in Edina. We have more CT scanners on France Avenue than there are in all of Canada. So, I think that really looking at where we put resources is a huge piece. Looking at social determinants as a clear piece of risk, looking at financial incentives, and then having culturally sensitive nurse-led educational approaches, because we see there's a lot more trust sometimes from this perspective. And then finally, we learned some great things in the pandemic that we can do telemedicine, that when we were more effective at COVID-related messages, it mattered who the messenger was and how we leverage social media. So I have the great opportunity to work with Batala McFarlane. Her father started Insight newspaper, which is one of the longest standing Black newspapers in town, and she formed iHeal, the Insight Health Equity Action Lab. We've been working together just as I left the Department of Health and for the last 4 years now at the Minneapolis Heart Institute Foundation. But this is work that they've been doing to leverage their voice as a trusted source of news and information to the Black community here in Minnesota since the 70s, and appreciate that the role that they can have on health outcomes that way. This is actually a whole area now in journalism at the School of Public Health and the School of Journalism at the University of Minnesota to look at how messaging matters. And so this is kind of the stake that we've taken to improve cardiovascular health overall for the communities we see here. One of those I just want to focus on is our Heart to Heart series. Again, during the pandemic, and specifically with what we had going on in COVID, we realized that we needed to have a different way to get a hold of people. This is a podcast that Batala and I have where we are simply interviewing almost all Minnesotans, a couple of national folks, but the whole goal was for this to be a kitchen conversation of people's experience with heart disease, from primary prevention, from adverse outcomes during pregnancy, successes, failures, aortic valve replacements, ruptures, everything that you can think of, but just for people to be able to talk and share their experience of how they're ultimately changing things to promote generational health. And like I said, that's on all the different versions of iTunes and Spotify and all those things. This is from a partnership that I mentioned, Girls Taking Action, that we're doing with the Power of the People's Leadership Institute. And this specifically is a partnership that we also have with the Downtown YMCA. They have a an equity innovation lab where, again, we get to have these conversations earlier, just like the recycling movement. We know that part of the way that we get to older generations is through children. It's trusted resources to change this for them going forward and also for their families. So we've done community screenings with the YMCA. This is over on the north side at the Harold Mazzell Y, where we have our interns doing blood pressure checks. But again, as we talked about at the very beginning, the role of churches here has been well documented in terms of improving things for the cardiovascular space. La Princess Brewer at Mayo I'm a part of her faith steering committee where she has shown specifically improved outcomes for people of color with the role of the church. I would say, again, it's some of these simple types of things that we have to be able to connect the dots. There's no reason that we shouldn't be able to improve blood pressure for everyone through all sorts of venues, like the church, like the schools, like the barbershops, wherever people, pray, play, are at school, whatever the case is. But we need to connect those dots to not only be in the clinical setting, because we know that that's just not feasible for everyone. We also started some partnerships with the Divine Nine, and this one is specifically with the Kappa Alpha Psi Black Fraternity National, which is a partnership with Edwards Life Science. So I think these nonprofit, for-profit, public community partnerships are just such a huge piece of the long-term solution. So Edwards Life Science produces our aortic valve replacements, the new ones, the transaortic valve replacements or TAVRs. Again, everything that we have to show is that your rates of aortic valve narrowing or aortic stenosis have nothing to do with race. But right now, 90% of the people that get this special valve are white. So again, we've been doing these throughout the country where, again, we have access to young people just graduating, young people in school, and then the folks that have stayed in this Kappa Alpha Psi fraternity, and it's been amazing. We do our podcast from there, and we spend 4 hours talking about prevention and then a little bit specifically about valve health. I mentioned our Girls Taking Action. Here we are at the Capitol. They did a mock policy session so they can appreciate how health isn't just determined in the clinic, but it's also determined by the laws and policies that we have in our state. So for us, I think in conclusion, we've learned that we have to really start think different about who we're solving for. It's very clear to me as a practicing physician that we're usually solving for what's easy for me and what makes my day faster and smoother. From a research perspective, who we're enrolling, how we find mutual interests that aren't only the academic research, but actually matter to those most experiencing the disparities we have. I think it's critical, we heard this over and over, that we recognize the past as we move towards solutions. And finally, do we need more data, or can we move to a point of action? I'm going to close out here. This is, I'm thrilled to co-lead the 2035 state plan for reducing disparities, removing barriers to good health, and increasing quality care, specifically for Minnesotans' cardiovascular disease, stroke, and diabetes. I've been a part of this committee since 2007, and this is a completely different looking set of goals where you can see health equity, I hope, throughout, and the voice of the community. So we'll see where we get. We got some time, but we're going to have to change how we do things. So with that, I would love to take questions, thoughts, comments. Yeah.
One of the middle slides, you pointed out the difference between American-born blacks and foreign-born blacks, and then you just said something about, anyhow, can you talk more about that and how you understand that difference?
Yeah. So right now, I think probably many of you know that we have the second largest population of Somali immigrants compared to Somalia. And right now, when we look at our health data, they are doing better than our U.S.-born Black population. And so, unfortunately, from a physician perspective, what I would say that I'm observing, obviously, like if we don't have the academic piece of this yet to say scientifically what all this means, but what people have access to is very different, right? For good or bad, to have the opportunity to come to as an immigrant now, free will, not to say that it wasn't from a very difficult situation with everything that's happening in East Africa now, but it's very different than generationally what many of our US-born Blacks have experienced. And unfortunately, just there's so much there, and that I have learned just personally growing up the way I have, in terms of this access piece. So I just would emphasize, my dad has his MBA. He was one of the first Black people to graduate from Stanford Sloan Business School. He has a JD. I mean, he's very educated, just like a lot of these statistics are. But his access to our healthcare system, growing up in a poor family, with a single mom 10 blocks from here, was completely different than mine. And that's how you start to learn how to access healthcare and what that looks like. When Medicare went through originally, it only covered half. It covered all white people that were 65 and over, but it covered half of our population of color because we didn't have the money as a country to afford it. And that was the political compromise that was made. So it's not been that long that Black US-born families have had anywhere near, which they still don't, the same access to healthcare. So there's a lot there that's different for US-born Black families than immigrants here. And the social determinants are a big part of that. Yeah. Go ahead.
Thank you. So monitoring online, and a question comes up about what can non-medical people do to support the system change, maybe the anti-racist efforts that you've been describing.
So, I think it's so critical. It's going to take so much more than the healthcare system changing, and the healthcare system, as you know, Gretchen, changes like the Titanic. It takes like 20 years. So I think, and that's been part of my thing, is the more that we can help empower people, individuals, communities, neighborhoods, churches, all the things that we're talking about, to understand that the flaws here are just throughout the whole system, and it's going to take all of us to change that. I mean, I think that's a big piece of like being aware when you see these disparities, which I'm sure there's articles out today, to not just say, well, oh, yep, there you go. That explains. Oh, that makes sense. More high blood pressure. No wonder there's more heart disease there. It's that person's fault. So I think everybody has a role in whether or not, if you work in a school, who's getting what type of discipline, what type of education, what type of, that piece of it. You work in a bank, who you're giving loans to, this is a multi-system thing. So it's not a healthcare system thing, right? It just is that our health, it is also a healthcare system thing, but our health is determined by all of these things. So I would imagine that the online folks that are asking that, we all have a role in whatever place we're showing up in, because a big part of this is racism in all of these different spaces, and it's subtle, and it just needs to continuously be unrolled, or I don't know what the right words are, addressed, that everybody has not just equity or equal opportunity, but true abilities to live a prosperous and healthy life. Yeah.
Hi, my name is Sheila. A couple questions, but a comment maybe about what was just said.
Yeah.
I'm 67, not in the working world. I don't have children in school, obviously. And for me, it seems like my role can be conversational with people I connect with in my life, in and out of the church. But the data here, I don't even know how to start, because there's so much sure, clear head data that I need to know and understand so I can spit it out. And my heart is there too, but I just don't know where to begin when I encounter an offhand comment by someone about this issue. I'm kind of stymied. I'm wondering if you have a comment about that.
Well, I guess I appreciate you being so honest and authentic about that. I think what I would just say, right, health starts when we're born, right? Unfortunately, it starts in utero, and that I have a whole nother story about being pregnant and getting my master's in public health and being told that my brain wasn't straight while I was taking care of patients because of everything that's happening in utero at that time. But let's just say it starts at birth. And so what are we doing as a population? What are you doing in those situations to be promoting health for the people, your family, friends, neighbors, parish members, whatever the case is? Because for instance, right, we know that people live longer that go to church. Part of that is that community connection, but that's partially, then there's the opportunity that, health doesn't live in silos. It's how we move, it's the stress in our lives, it's getting adequate sleep. And we have so much work to do as a society, period, on health, but then it's just worse if you're a woman, and if you're a woman of color, it's the worst in terms of the challenges that are laid upon you. So, some of the data that's been done on tethering and things about what racism does, and what it feels like when people are walking on a sidewalk and someone crosses the street when they see you, the impact that has on your blood pressure, the impact it has on your blood pressure when you're a young Black boy and you get pulled over, and what you might experience. So I think those need to be the things that we're not just talking about, but we are together saying this adds up to that. And I think you have an opportunity to be a part of that change, even though you're retired or you don't work in healthcare, because this is everywhere. but it's because it's so broad, it's not a reason to not take action, you know? And I think it's just, I don't know, I'm sure there's all those metaphors of ants or whatever. It's going to take all of us doing little tiny things, because that's how we got here in the first place. There were some big things like slavery, but we have gotten here because we've allowed sort of the typhoon to continue, and now we just have to, it's not going to just change because I came here and spoke today. It's going to take slow and continuous and not just one effort to undo this. Yeah.
Any other questions?
Thank you. That was a very informative talk,
Thank you.
very thoughtful, and I think as a neurologist, I can say that a lot of what you're talking about actually applies across the board in healthcare, not just in
Right.
cardiovascular disease. One concern I have, having done a little bit of research funded by the NIH, is that our federal government requires researchers to classify
Yeah.
study entrants by their race and ethnicity. So the implication is that race is genetic
Yeah.
and ethnicity is learned or acquired.
Yeah.
I am very concerned that our federal government is supporting studies that bake in racism to
Totally.
them, and then we can spend a lot of time after the studies are published and people get promoted academically
Exactly.
for what they're asked to do, and the biostatisticians make
Yep.
whole careers on trying to tease out little
Manipulate
factors
numbers,
where
yeah.
blacks are different from whites, or Pacific Islanders are different from whatever genetic group you think differentiates humans who actually have very overlapping genomes.
Exactly.
And are not, I think, evolving towards subspecies where blacks are actually really different from whites.
Right.
It seems to be creating studies of the types that you used as bad examples. For example, treatment
Vital,
of
yeah.
hypertension with diuretics and
Yeah.
calcium channel blockers versus ACE inhibitors for
Yes.
whites. Is there anyone at a federal level who's linking in with these efforts to remove these requirements and take
Yeah.
racism out of the studies?
It's such a good question. You must be Michelle's husband, by the way, right? Yeah. I'm figuring this out.
I don't
yeah.
think we look alike, but
No, but I heard
Yeah.
just enough about you beforehand. So, but it's such a great question, and my honest answer is not that I'm aware of. I couldn't agree more with you, but that's where, like, I hope you and myself, and we only have. I know my voice isn't massive. Like, the NIH is not calling me frequently and asking me my opinion, but it's a huge problem. And it's another piece of just that subtle, like, it's so easy to have your own career grow and say, I'm doing some of the right stuff. I'm studying the data. I'm putting out papers on this, but it's part of the problem. And so that's where again, my answer is I don't know that they're actually doing the right stuff that way. But I think it absolutely has to change. And there's so much to what you're saying. There's so much funding going into just how do we accurately label people? I know Alina, the system that I'm a part of, like, which parts should we add to the medical record? Which boxes should we have that people check? And that's not even the problem. It's a waste of money to be doing that at all. But, there's enough inertia, unfortunately, that's like, but we're doing right by having these boxes to check so we can look at our data better when we don't need any better data. Yes, if we have more data, we'll find out the disparities are worse than we know. But we need to change it into action. Like, it just has to, we know, do we have it perfectly figured out? No, but we have to get away from just analyzing the data. But that is, you're spot on. It's a huge issue. Yes, we have to wrap up, I know.
Yeah, we have time for one more question.
No.
I also thank you for being here and
Yeah.
for everything you've shared with us. Would you like to tell us more about what you're up to in your primary job right now? I've known of the Heart Institute.
Yeah.
I didn't know they had a foundation. I think of foundations as either raising money or distributing money. Do you do other than those two things?
So the quick answer is we're doing a lot of efforts within the community. So we're trying to translate this stuff. We do a lot of pilot research things right now. We went through our own data with those fourth trimester things, saw that we had the disparities that we thought we did, and then offered a prospective going forward study with free healthcare. With a partnered organization to see if we took out you having to come to the clinic and offered, we come to your house, does it improve gestational diabetes and all those things, which we're about to publish. But they're all pilot things, right? We're not funded to translate them. So we're trying, but it's not perfect. Yeah. Thank you.
Yes.
Yeah.
So thank you, Courtney, for sharing your perspectives and your experiences. Please join us next Sunday for the joint forum with the adult education team as part of Westminster Martin Luther King weekend events, when we will welcome co-directors for racial justice from the Minnesota Council of Churches, the Reverend Jim Bear Jones and Reverend Pamela Goji.
I just want to amend that. We will welcome one of the co-directors for racial justice, Pamela Gojeri, which Michelle nailed it on the name. Well, we're also very fortunate that we will welcome the Reverend Dr. Curtis DeYoung, who is the co-executive director of the Minnesota Council of Churches, and he has written a book called The Risk of Being Woke. Both of them will talk about the 10-year, very ambitious, but very much needed, as we heard in Dr. Jordan Baechler's presentation, the work to make sure that every person, no matter what their zip code is or their racial background, lives well in Minnesota. So the Minnesota Council of Churches is taking up that work, and that's what we'll hear about next week, and we'll be in the Westminster Hall instead of here. Thank you all.